I deliberately picked a vague topic when I was asked several months ago, but I then really decided to really give an update on our efforts to target HER2 in this talk. Briefly our disclosure, Baylor College of Medicine has a relationship with Bluebird Bio and Celgene. Since I knew there were lots of CAR introduction slides, I skipped mine and rather sought to really remind the audience of Paul Ehrlich, where at least in Germany this year we are celebrating his, the anniversary of his 100th death. And the Paul Ehrlich Institute actually came out with a very nice cartoon. As most of you probably know, Paul Ehrlich kind of is the father of humoral immunity, and he developed the so-called side chain theory, and they came up with this very nice cartoon, Side Chain Therapies Then and Now. But I was a little bit disappointed because I really forgot the chimeric side chain, which really probably hopefully will have the biggest impact on the field of immunotherapy for cancer. So with that, I, as mentioned before, would like to really review our efforts in developing HER2-CARs for the clinic. And while the initial development was rather tedious, our hope is that with the interest in the field right now, we will be able to make much faster progress in the next couple of years. Just to remind everyone, HER2 is an orphan receptor. It belongs to the EGFR family of receptors, and it's gene amplified roughly in a third of breast cancers, where trastuzumab as well as TKIs have significant anti-tumor activity. However, a large portion of solid tumors express HER2 at low level, not only in pediatrics, but also in adults. And in general, Herceptin and TKIs are less effective. For osteosarcoma, COG tested this actually several years ago and asked the question, is chemotherapy plus Herceptin superior to chemotherapy alone? And unfortunately, there was no significant difference in overall survival in that particular trial. This just highlights the difference of expression of HER2. In the top, SKBR3 is a gene-amplified HER2-positive cell lines, whereas other solid tumors and brain tumors express moderate levels of HER2, but they're definitely positive in comparison to a HER2-negative breast cancer cell line, MDA MB468. If you now ask in vitro, are these cell lines sensitive to Herceptin, the answer is clearly no. Shown here first in a proliferation assay, where a gene-amplified cell line is inhibited by trastuzumab, whereas low HER2-positive osteosarcoma cells are not. And then if you do a complement assay, again, the gene-amplified cell lines is killed, whereas the low expressors, so to speak, are in the bottom close to the HER2-negative cell line. So for our studies using HER2-CARs, we didn't use a trastuzumab SCV, but an SCV which was provided to us by a collaborator and friend of mine, Winfried Wells, who's now at the Georg Speyer House in Frankfurt. And we used a second-generation CAR for most of our preclinical studies, and traditionally our center have used retroviral vectors to transduce cells. This just shows that in contrast to the antibody, HER2-CAR T cells recognize a panel of HER2-positive cell lines as judged by IL-2 production, whereas a HER2-negative cell line is not killed. And one of the criticisms of these type of experiments were from the beginning, you've now generated CARs which recognize HER2, what about normal tissue? This, of course, is very difficult to do in the end. However, we obtained some primary endothelial cell lines and in the end performed similar co-culture assays and looked at cytokine production. And what you see here on the left, HER2-positive cells, which activate HER2-CAR T cells, whereas normal cell lines are not activated. One of the advantages, I think Crystal mentioned, is of these type of cells is that hopefully we can kill cells which are resistant to chemotherapy. And in the context of osteosarcoma, we looked at so-called progenitor cells, or looked at cancer-initiating cells. And while osteosarcoma cell lines are relatively sensitive to methotrexate, which is one of the standard chemotherapeutic agents currently used, if you grow the same cells in a sarcosphere condition, you see that these sarcospheres are resistant to methotrexate. However, if you now use HER2-CAR T cells and ask the question, are these sarcospheres destroyed by CAR T cells in an antigen-dependent manner, you see if you focus on the fluorescence up top, HER2-CAR T cells are able to destroy GFP-labeled sarcospheres, whereas non-transduced cells cannot. We also tested these type of cells in animal models. This shows a metastatic sarcoma model, where we've shown a regression of HER2-CAR T cells, and then we also shown it in glioma model. And here it is in an autologous setting where we generate primary glioma cells from patients, genetically modify these with luciferase, and then graft them into the brain of SCID mice, and then inject HER2-CAR T cells, which have been prepared from the same patient. So while we were kind of excited to kind of move that to the clinic, at the time we were, so to speak, ready to go. As most in the audience know, there was a death of a patient on a HER2-CAR trial who received quite a high dose of T cells with a third-generation CAR after a conditioning regimen with IL-2. And we really felt that it was dose-limiting toxicity. So to speak, like any other chemotherapeutic agent, if you give too much, the patient has a chance of not surviving the dose. So after talking to the FDA, we were asked to start at a very low dose. And Crystal, I know you said 10 to the 6 is low, but we almost had to start at homeopathic T-cell doses. But the only other option we had gotten from the FDA to develop a non-human primate model, but that probably would have been very difficult to do, and also probably would have been not the best, because if you look in the Herceptin literature, the biggest complication of using HER2 or trastuzumab, cardiomyopathy, was not seen in any non-human primate studies which were performed by Genentech before the antibody went into the clinic. So we, on this particular study, enrolled 19 patients. The majority had osteosarcoma, and I think the disease status is pretty typical for these group of patients. The majority had lung metastasis, and in these patients had failed multiple lines of salvage regimens. And this just shows some of the characteristics of the cell lines. You can reliably generate genetically modified T cells from these heavily pretreated patients. And if you look in cytotoxicity assays, these cells recognize HER2-positive cells, NCI-H1299, which is a lung cancer cell lines, and LM7, an osteosarcoma cell line, whereas HER2-negative targets are not killed. We asked 4 simple questions. Is infusion safe? Do these cells expand in vivo? Do they traffic to the tumor sites? And do they have anti-tumor activity? In regards to safety, we did not see any elevation of cytokines. We saw a transient increase in IL-8, but to be honest, although we tried to figure out where the IL-8 is coming from, at least up to now, we were not able to kind of discern the source. If you look at detection of genetically modified T cells in the peripheral blood of patients, regardless of dose level tested, the highest PCR value was at the 3-hour value, and then there was almost like an exponential decline. However, we were able to detect cells reliably up to 6 weeks after T-cell infusion, at least at the higher dose levels. And that is shown on the next slide on your left side, where you can see if you infuse more than 3 × 10⁶ cells per square meter, you can detect cells at the 6-week time point, whereas if you infuse lower doses, we were unable to detect cells. And then on the right side, you see long-term follow-up. I would say while there were 1 or 2 patients where we could detect transgenes at later levels, it was the majority of tested samples were negative. I'm sorry, I'm on the wrong. If you now ask the question, do these cells traffic to tumor sites? As most of you know who do clinical trials, it's very difficult to build in biopsies which are invasive into these type of phase 1 and 2 clinical trials. So only patients who had, we only had material from patients who underwent procedure which was deemed appropriate for their clinical course. And here you see some immunohistochemistry showing CD3 cells at the tumor site. And at least for 2 of the samples, we also had fresh frozen samples and could do real-time PCR showing a PCR single at the tumor sites where corresponding single at the blood was negative. If you look at overall outcome of these patients, 4 patients had stable disease, 3 patients had their tumor removed, 1 of the tumors was necrosis. And I think the kind of, although we have not seen dramatic responses as on any other solid tumor trial, I think what is kind of interesting is that none of the patients who had their tumors removed had recurrence, which is very different from the natural course of osteosarcoma, where you just get recurrent over again. So we are actually, I think one could say, the glass is not completely empty, looking at this type of data. So the conclusion of that part of my talk is that HER2 CAR T-cells have anti-tumor activity in preclinical models, and the evaluated cell doses are safe. However, we did not observe T-cell expansion. T-cells persisted for up to 6 weeks. We were able to show that T-cells home to tumor sites, and there might have been some clinical benefit. And this kind of shows kind of some of the other solid tumor clinical trials with CARs which have been published so far. And I would say that kind of the results of our trials are very similar to what have been done by other investigators. And so I don't believe that it's specific to the HER2 CAR we have used for these type of studies. So as a lot of investigators or speakers mentioned already, the question is really, why are CAR T-cell therapies for solid tumors so far less effective? And while as others in the audience, we are heavily also focusing on redesigning the CAR, looking at other antigens, or trying to counteract immunosuppressive cells or the products they make in preclinical models, I thought it would be more interesting for the audience to really ask 2 questions which we are currently asking in the clinic with the current CAR we have. One is, does the expression of the HER2 CAR in virus-specific T cells change the fate of infused cells? And the other question is really, does lymphodepleting chemotherapy can be safely done with HER2 CAR T cells? The concept of expressing CAR in virus-specific T cells was developed by Claudia Rossick when she was a postdoc in Malcolm Brenner's lab. And the basic idea is summarized on this slide, where you take EBV-specific T cells, you express a CAR, and these then are able to recognize the cancer cells. But because of the presence of EBV in memory B cells and the presence especially of also CD4 cells within everyone who is EBV seropositive, you get a cognitive help. And several investigators in our center, including John Petro and Barbara, tested that in preclinical models. And Crystal showed, I think, one of the slides from the clinical study, which resulted from this preclinical work. For our studies, and this kind of now switching gear a little bit, we wanted to focus on another latent herpes virus, and we picked CMV because we were interested in also exploring HER2-CAR T cells for brain tumors. And there is an increasing literature that subsets of GBMs are CMV positive, and actually Nabil's group recently published a paper looking also at pediatric gliomas, and I would say that the findings are very similar to the adult literature, that the majority of pediatric high-grade gliomas also express IE1 and PP65, two of the immunogenic CMV antigens. CMV has been actively targeted in a vaccine approach by several investigators. So we really wanted to take advantage of the CMV-specific platform and generate T cells which express, which are CMV-specific and also express the HER2 CAR. For the study, we used, I would say, a now outdated method of generating CMV-specific T cells, where PBMCs are activated overnight, then they are transduced with an adenoviral vector encoding PP65, and then we use autologous lymphoblastoid cell lines, which are further genetically modified with the recombinant adenovirus to generate CMV-specific T cells. And during the expansion phase, the cells are also genetically modified to express the CAR. This just shows us that it's feasible. Using glioma patients, we get very nice expansion. If you do ELISpot assays, expanded lines are specific for PP65. And if you do functional analysis doing cytotoxicity assay, if you focus on the red line, you readily see that autologous GBMs that are infected with CMV are killed by CMV-specific cell line, whereas mismatched GBM cells which are infected with CMV are not. If you ask, do we generate cells which are truly bispecific when we genetically modify them, this shows tetramer staining looking at PP65 restricted NLV epitope, and you can clearly detect within the tetramer positive population HER2 positive cells. These cell lines still can recognize CMV as judged by ELISpot assays. There's really no difference to the non-transduced T cells. However, these cells now recognize also their autologous HER2 positive glioma cells. So we conducted a clinical trial, and this just briefly summarizes eligibility criteria. We infused 19 patients on this trial. The median age was 45, but there were actually also 7 patients who were less than 20. The median number of surgeries was 1. All had received radiation, 14 out of 17 temozolomide, and the median number of salvage therapies was 1. This just summarizes the generated cell line. Transduction efficiency was a little bit lower than using CD3, CD28 activated blast. And this showed the ELISpot data. On your right, the lines were all positive for PP65. Not surprisingly, they had no activity against CMV IE1, and the specificity for adenovirus and LCL was variable, but in the end is very comparable to the lines our center had generated from healthy donors for some of our other clinical trials in the post-transplant setting. This just shows extensive phenotypic analysis on the left, and then on the right shows cytotoxicity assays where cell lines modified or unmodified with the CAR are able to kill autologous EBV-positive lymphoblastoid cell line, whereas only the HER2 CAR-modified T cells can recognize high-grade glioma, which is HER2 positive. So we wanted to ask 2 questions. Do HER2 CAR CMV-specific T cells expand in vivo? And the second question was really, do HER2 CAR CMV-specific cells have anti-tumor activity? Unfortunately, we did not see significant expansion of the infused cells on all dose levels tested. And just as a comparison, I put back the data I'd shown before. If anything, you kind of sense that even at the 3-hour value, probably virus-specific T cells have a different biodistribution than CD3, CD28 modified cells. Even at the 3-hour value, at least in the peripheral blood, there are a lower number of cells than with CD3, CD28 activated HER2 CAR T cells. If you look at later time point, I would say it looks very similar. Again, we were able to detect genetically modified T cells sporadically for up to a year. But again, if you compare that directly to the CD3, CD28 CAR T cells, there was no significant difference. We also performed ELISpot assays looking at the frequency of PP65-specific T cells in the peripheral blood of these patients over time, and there was really no significant difference. You might even say, wow, pre-infusion, the level is slightly higher than at 6 weeks, but that is a problem with some of the studies we do while the patients are in-house for the pre-infusion samples. Most of the 6-week samples are chipped overnight. So therefore, what we normally like to do, have an internal ratio where we compare the infused specificity against one which is at baseline within the patient. So here on the right side, the PP65 to IE1 ratio is shown, and at least there is no decrease. If anything, there might be a slight increase over a 6 weeks period. If you kind of step back, while these results on one side are disappointing, they are very much in line with all the adoptive T-cell therapy studies which have been done to protect for virus-associated diseases after stem cell transplantation. And also our center has done with EBV-specific T cells to treat EBV-positive lymphoma or nasopharyngeal carcinoma outside the transplant setting. And I think the rule is that you not only have to have significant lymphodepletion to get expansion, but you also, in the end, must have antigen present. So if you now think about the glioma patients, these patients were not lymphodepleted at the time when they received their cells, and at least by real-time PCR, had no increase of CMV in their peripheral blood. So the results are very much in line with what we've seen on our other clinical trials using virus-specific T cells. If you look at outcome, we had one patient who incidentally had no surgery because of the central location of his GBM, who would say had unequivocally a response by MRI, which lasted for up to 4 months, and then in subsequent scan, the glioma progressed. 7 patients had stable disease, of which 3 are still alive 22 to 27 months after the T-cell infusion. This shows the overall survival curve, and at least in the glioma field, everyone always says, nah, pediatric patients have a better outcome than adults. But if you really look here, there's really no difference if you look at patients who were treated who were less than 20 versus patients who were older than 20. So finishing up with, and that is really ongoing work, this question of lymphodepleting chemotherapy. And you can probably imagine that we were probably worried is the wrong word, but we wanted to be very cautious given the deaths on the NCI trial. So in the end, what we decided is to have one patient cohort who only received fludarabine, and then in the second cohort, we decided to use Cytoxan and fludarabine. And for those in the audience who are lymphodepleting aficionados, we reduced the Cytoxan dose by half. So the standard NCI, at least TIL therapy regimen, is 60 milligrams per kg of Cytoxan twice. We've completed the fludarabine arm, and actually the first patient on dose level 9B is day -4 today. So if you look at the safety aspect of using just fluid alone as a conditioning regimen, the first patient had no symptoms. The second patient had fever, a CRP up to 8.9, and was managed outpatient. And the third patient had fever, some hypotension, and a transient oxygen requirement. And looking at some of the grading schemes for CRS probably fulfilled the criteria of having a CRS grade 2. This shows lymphocyte count at ANC. To be honest, I was quite surprised about the transient nature of lymphodepletion losing fludarabine alone in solid these sarcoma patients. Of interest, and it will be apparent on the next slide, one patient was chronically lymphodepleted because of being heavily pretreated prior coming to us, and we really didn't see any significant neutropenia with giving fludarabine. If you look at expansion, so in 2 patients, we now see actually quite dramatic expansion, and the first value is a 3-hour value between 2 to 3 logs. However, it was transient in nature, and by 6 weeks after infusion, the cells were, had almost returned to baseline. However, the patient who was chronically lymphodepleted getting fludarabine really didn't make a difference. And although it's n equals 1, what at least it's telling me is that what is probably more important than lymphodepletion is really the delta. That when you have someone who's lymphoreplete and you reduce your lymphocyte count, then you probably have homeostatic cytokines available to enhance expansion. However, in a patient who is chronically lymphodepleted, his or her rheostat is probably set for much lower levels. So you probably need stronger lymphodepleting chemotherapy to get to, so to speak, to a right environment. Incidentally, in regards to outcome, 1 patient had stable disease and 2 patients had slowly progressive disease. So in conclusion, adoptive transfer of HER2-CAR and HER2-CAR T cells in humans, the evaluated cell doses have been safe. We, without lymphodepleting chemotherapy, really have not observed significant expansion. And I think the question if chemotherapy can be used to safely enhance HER2-CAR T-cell expansion is a work in progress. In the end, I would like to thank my lab and also our center. I especially want to thank Nabil, with whom I developed HER2-CAR T-cells, so to speak, from the bench to the clinic since 2002, I think. Thank you so much.